Unfortunately, people's skin conditions and people's chronic conditions, such as diabetes, are somewhat ignored at this point during the pandemic. And of course, people's problems are getting worse. And we're actually seeing that now in our clinic, that there's a lot of neglected diabetic skin problems. And therefore, it makes it even more important that we really do know what's happening to our diabetic patient's skin. I would like to get on straight away because with the lecture, I'd like to divide the problems of diabetes and skin into those problems that happen more commonly in diabetes, but can happen in anyone. And those problems that are just specific, only happen in diabetes. They need special ways of diagnosing them and treating them. Very important in diabetics, the skin problems are diagnosed and treated early, because diabetics tend to have problems which are much more severe and extreme and difficult to treat. Now, non-specific problems in diabetes, and I know there's a lot of non-medics in the audience. They say about a third of patients will get major skin problems with diabetes. We've all know about Candidiasis or thrush. Thrush can happen in the mouth. It can happen in the groin area, genitals, nails, the skin. We know impetigo is much more common in diabetics. Impetigo is an infection that commonly happens in children, but in diabetics, it can happen in adults. There's a condition called psoriasis, which is very fascinating. We know that this condition called psoriasis, that 50% of the patients with this skin condition called psoriasis have got resistance to insulin and therefore the potential to become diabetic. There's also conditions such as boils in the groin, infections of the skin and infections of the hair follicles. And also in particular, there's a problem which is particular to Asians called Acanthosis nigricans. It's not specific to Asians, but it's very common in Asians. And in Asians, it's particularly distressing. So I'd like to spend a bit of time on that because in my clinic, it seems to be a major problem and very poorly dealt with, unfortunately. Now, candidiasis, we all know, we've all probably had when we have sweaty feet, toe web infections. But in diabetes, it's not just toe webs, which is what everyone gets. Diabetics tend to get it in the finger webs, which is rather unusual. Unfortunately, a lot of candidiasis in diabetics can't just be treated by creams alone. And if possible, treating with drugs such as itraconazole, fluconazole, oral drugs are much more effective. But as we all know, diabetics can have lots of different medical problems. And therefore, if the diabetic is on a drug, if you're on a drug such as amlodipine for your high blood pressure, we cannot give these itraconazole medications because there's a lot of interactions between these medications. So if you're a clinician out there, before you prescribe the azoles, itraconazole, fluconazole for candidiasis, make sure you look it up in the BNF, because these drugs have a lot of interactions, because a lot of our drugs, our diabetics are on statins, the lower cholesterol. If you give these azoles to patients with these antifungals to patients that are on statins, you cause muscle pains. So be very careful. If you don't, Lamisil or terbinafine tablets don't do very well in candidiasis, so you may be stuck with topical treatments. Impetigo, this is a bacterial infection. There's two bugs that cause it. One is called Staph aureus. The other is called Streptococcus. Now, this sort of infection can happen in children, but in diabetics, it can happen in adults. Very important it's recognized in diabetics because if it's not treated, it can spread, it can scar, and it can also lead to a blood infection, which of course can be a lot more serious. Now, this condition called psoriasis is very interesting. More recent work has suggested that these patients with psoriasis, the psoriasis patch itself makes chemicals that makes the patient obese or make the patient gain weight. That gaining weight secretes chemicals that makes the patient more resistant to insulin and makes them more diabetic. The more diabetic they are, the more psoriasis they create, and the vicious cycle starts. So in a lot of patients, when you look at their psoriasis, in a lot of diabetics, you should look at their skin, because if they have psoriasis, treating the psoriasis tends to improve the diabetic control. It seems if you have severe psoriasis, you can't actually have one without the other. You need to do both. Very interesting, I think. Folliculitis is an infection around the hair follicles, more common in diabetics, treated with antibiotics such as flucloxacillin, because the most common bacteria that causes it is a bug called Staph aureus. And then there's an infection which isn't around the hair follicles, but it's deeper in the skin, called cellulitis, which is much more common. This can be quite serious and lead to blood poisoning, and this patient should be admitted to hospital because the diabetic control goes out of control. So intravenous antibiotics, please. Now, this condition called acanthosis nigricans, this can happen before the patient becomes diabetic, i.e. the patient has what we call insulin resistance. This is very distressing because this is very common in Asian patients, and you get great big dark patches in the armpits, but also dark patches around the neck and this sort of furry appearance to the skin. Now, unfortunately, this darkness can also appear on the face as well, which can be very distressing. The ladies can be quite young, and this is they're in their pre-diabetic stage. Now, the key is to make sure they're not diabetic or insulin resistant. You can use skin lightening creams combined with vitamin A creams in order to smoothen the skin and get rid of the pigment. But the ultimate treatment for this condition is to diagnose the diabetes and treat it. The condition automatically melts away. Now, here are the rarer things that happen in diabetics. There's something called diabetic democracy. This is where you get itchy or non-itchy patches. They look very distressing. And this is related to the amount of control of your diabetes. So if you have this problem and you're diabetic, the minute we get decent control of your diabetes, within 3 months, this problem should go. And this is called diabetic democracy, one of the commoner problems in the poorly controlled diabetes. And this is another example of diabetic demopathy. Interestingly, this patient has another condition, concomitant, called granuloma annulare on the foot there. That's good for the medics in the crowd. And then there's a diabetic bullae or diabetic blisters. They're large blisters. They can vary between 1 centimeter and 20 centimeters. Again, these sort of things can only be treated by bursting them, dressing them, and controlling the diabetes properly, because once the diabetes is properly controlled, then you'll find that this does not happen. And this is where the blisters have burst. This is an interesting sign. It's called the prayer sign. This is a sign where the patient can't actually do this. They can't pray properly, simply because the diabetes has made the skin so thick, they can't bend their fingers properly. And as soon as you control the diabetes properly, the patient can pray properly again. Again, it's all about the diabetic control. Diabetic foot ulcers, this is where the nerve and the blood supply is damaged. The patient can't feel pain and therefore will stand on that area for a length of time and the skin gets damaged. Very difficult to treat. Again, a sign of poor diabetic control. This is a rarer condition called Necrobiosis lipoidica. This is not related to how well your diabetes is controlled. It happens in young diabetics, mainly insulin dependent. And we have developed new cosmetic laser ways of treating this. You have to be very careful, but we have now developed new novel ways of making this almost look normal. You can imagine a young person having this on their shins. It would be very distressing. And it can also ulcerate like this. It can be painful. It can be itchy. Thankfully, we've now got very new methods to treat this. I tend to treat something inflammatory like this with intralesional steroids. Once the areas become non-inflamed, I'll then use a series of lasers in order to treat this, very specialized, and this is a lecture in itself. Happy to give, though, at any point. This is a rather harmless condition called granuloma annulare. It's non-itchy. It looks like this. Some people will mistake it for a fungal infection, but it's not scaly. Topical steroid or topical tacrolimus will clear this in about 2 months. I prefer the tacrolimus because it doesn't thin the skin. Granuloma annulare is meant to be more common in diabetics. It can be localized or generalized in this form, both treated in the same way. So in summary, there are many skin problems in diabetes. Those problems that are more common in diabetics and everyone else gets we call non-specific. And then there are those problems that only happen in diabetics that can be or may not be related to the amount of control of the diabetes. Thank you very much.